Hi, everyone. Thank you for joining us this morning. Welcome to session 1A, new guidelines for the use of slow-release oral morphine as opioid agonist therapy. I'm Christina Henry, and I'll be the moderator for this session. Before I introduce our speakers and get started, I just wanted to review a few pertinent items in case you missed them earlier. I just wanted to address again how to increase your view of the presentation slides because it does appear quite small when you're initially looking at it. So if you did miss it, all you need to do is just right click on the presentation slide area. Then you'll get an option to select picture in picture. And then you'll get a pop-up window probably in the bottom right of your computer screen, which you can then just kind of click and drag the arrows and size it how you like. And that should help with the view issue. During the presentation, as questions and comments arise, just due to the format here, it's easiest if people just drop them into the room chat. You can open that by clicking the chat icon at the top of your screen and just selecting current room. And then at the end of the presentation, we'll have some time set aside to address all the questions and comments, but you'll also be able to ask questions aloud at that time by raising your hand. When I call on you, you'll just need to hold down on the hold to talk button so we can hear you. And certainly if I've missed anything in the chat, make sure you raise your hand so that we have time to answer everybody's questions today. So with all that aside, I'll move on to introducing our speakers for today. Jason Rodgers currently attends St. Paul University in Ottawa, studying human relations and spirituality. Upon completion of undergraduate studies, he will be continuing on to do a Master's of Social Work. As well as full-time studies, Jason is employed by Somerset West Community Health Centre as a harm reduction worker and a full-time peer harm reduction worker. He is the father of 4 children. Informed by lived experience, Jason has a passion for driving systemic change for people who use substances in the community. Ashley Smoke, spirit name Gatherer of Medicines for the People, is an Indigenous Two-Spirit parent of a neurodivergent toddler. They have lived experience with drug use, criminalization, child apprehension systems, and other areas of marginalization. Ashley does research around drug use and drug policy for many organizations and advises dozens of agencies on their policies and programs. Ashley works as the Indigenous Harm Reduction Knowledge Mobilizer for OHAS and consults for a number of organizations, including Dr. Peter Centre, Public Health Ontario, and the Public Health Agency of Canada and the Canadian Government, Public Health Ontario, and the Ontario Drug Policy Research Network. They also co-founded the Ontario Network of People Who Use Drugs and Tweak Easy Coburg, where they advocate for the well-being of people who use drugs. Suzanne Turner is a family physician and an associate professor in the Department of Family Medicine at McMaster University. She is an intrapartum care provider as part of the Maternity Center of Hamilton and the Program for Substance Use and Pregnancy, PROSPER. She has been honored for her teaching excellence in family medicine and is a sought-after speaker at family medicine conferences and obstetrics meetings. Her research interests include the pharmacological treatment of perinatal substance use disorders. And I might add, she's also a valuable contributor to our listserv, as those questions often arise, and Suzanne's kind of our go-to for that. Thank you all for joining us today and sharing your expertise with us. So I look forward to your talk.
Thanks so much, Christina. That's great. I'm just going to share my my screen here. Okay. So today, as we talked about, we're going to talk about slow-release oral morphine as an opiate agonist therapy. I probably don't need to tell everyone in this group about the urgent need for expanded treatment options. I'm hoping that what you'll get out of our presentation today is a little bit about the process that we use to come to the consensus about these guidelines, but also really the need to listen to people who use drugs about the need for treatment options that are congruent with what their goals are for treatment. Obviously, we need rapid, low barrier access to person-centered opiate agonist therapy, and that's certainly not the experience that we've had with things like methadone in the past. And we know that methadone prescribing, particularly in Ontario, has a long history of stigma and significant barriers on all parts of the treatment process, both on the provider and prescriber side, but also on on the patient side. And really what what this boils down to, and I think all of us here are trying to address this, but the failure to meet what my patients are telling me are their self-identified needs is contributing to what we're seeing in terms of this huge number of relapses and death. So our historical approach, this is based on a BC SSSU diagram. I really like it because it really kind of puts the historical approach into perspective. So, you know, in the middle, we have our agonist therapies. There's this controversy about which one is better than the other. Are we advocating for buprenorphine? Are we advocating for methadone? Withdrawal management, hopefully we're not, you know, we're doing under very careful situations. And then really this situation with slow release oral morphine not being accessible because it needs to be specialist led, and it's really an alternative approach that, you know, many people don't have access to. So if we kind of look at the guidelines as they've been set out, if we go back to CRISM, which is the 2018 guidelines that were supposed to sort of inform us nationally in terms of the management of opiate use disorder, buprenorphine was much, much more favored over methadone. There were very specific situations where you might use methadone, and SROM really wasn't on the radar in terms of slow release oral morphine. We go to sort of the CAMH, the Centre for Addiction and Mental Health here in Ontario. They came out with their synthesis of Canadian guidelines for treating OUD. They basically said buprenorphine is favored over methadone, maybe not as much as the CRISM guidelines, but both of those were considered, you know, first and second line, much over SROM. And this was, you know, sort of a bit different than the take of Medify in 2021, where methadone treatment for people who use fentanyl guidelines came out, and buprenorphine and methadone were sort of considered equivalent. And then SROM was considered either adjuvant therapy to methadone or a more specialist-led intervention. And then in 2022, if you look at the BC Opiate Use Disorder Practice Update, they kind of said something that was a bit forward thinking in terms of saying that all of these really should be considered equivalent, and we really should be using patient-centered approaches. So what this kind of led us to was, we'll talk a little bit about how we came to the guidelines specifically, but what I'd like to do is turn it over to my co-presenters to kind of talk about the patient experience or the experience of people with lived experience in terms of why SROM is a really important component for us to consider.
Hi, I'm Jason. I am a peer advocate for you know, people within my marginalized group, and from a personal standpoint, I was given the opportunity to try something different in my recovery, and personally, through given that choice, I found that it empowered me to. It really propelled forward my recovery. Not that I had a goal of abstinence in mind when I started, but certainly I came to that conclusion in my recovery. So just to this slide here, just kind of goes over a case study of, or an experience of somebody. And this is kind of my story. And so now I find myself advocating for this choice because I think people, when given the choice, it does empower people in their recovery. So, and whatever method they choose. So, because choices are good. So, thanks.
I think for me, I was on methadone and I started using fentanyl, and like nothing was reaching my tolerance level, like, and I was at like the max amount of methadone you could be on, and still like it wasn't working and it wasn't lasting. I was dosing twice a day, like it still wasn't working. So nothing was helping. And so I found a doctor that would prescribe slow release oral morphine. And when they did, I found a complete difference in just like the way I could even function day to day, and like just do my tasks in like I had more energy. I was able to just like actually focus on my life instead of other things like drugs and stuff. But yeah, I think when I did get that prescription, I noticed it was working, and my methadone doctor, because this was in 2020, and my methadone doctor said, no, like, I'm not going to prescribe you methadone if you're on that. And he kicked me off of methadone. So that's why like, when I heard about this project, I was so excited because I was like, yes, finally, I can help make a difference and make sure that people don't go through the same things I went through.
That's amazing. So thanks for sharing that with us. And you'll see that our peers or people with lived experience were a really important part of this project. So as you may know, there isn't that much data in the literature to support slow release oral morphine as a treatment or an opiate agonist therapy. And so we really went through a pretty large methodological search as a group to look at the key components, so morphine, slow release morphine, Cadian, which is the 24-hour slow release morphine that we use. And we also went through kind of the titles and the abstracts of identified articles, and we'll talk a little bit about those, but we also went through gray literature, including provincial and national guidelines, not only in Canada and North America, but also in Europe, where there has been some use of slow release oral morphine for a much longer period of time. And really, to put into context, we limited our search to 1996 onwards, and only those things that were published in English. So some of you may have some knowledge of some of the literature in Europe that's not published in English, and those would be excluded as a result. So this was a really interesting guideline team, much broader perspective than other guidelines that I've been on. And I really loved the component. There were 3 physicians. This is not what we look like. 3 physicians involved. There was a pharmacist and a nurse practitioner that obviously brought very rich medical experience. And then our 2 people with lived or living experience were really, really instrumental in kind of providing a patient-centered approach. So we reviewed this literature. We had a iterative process. Basically, we had regular meetings where we discussed and refined the recommendations that we're going to talk about today. And we really came up with a consensus-based guidance document that you can access in the chat. Dr. Wyman has put the link there. It's still in the draft phase, and we welcome feedback on it. But this will show you kind of our second iteration after a formal review process has undergone. We don't use a grade format or framework for those of you who are familiar with guideline processes. The biggest barrier for SROM is that there's really a very significant lack of high quality evidence. And what is very different about this guideline compared to others in the medical community is that expert opinion and living experience has very high prominence. So you will often get expert opinion in this, but I think the lived and living experience is incredibly integral to what we've put together for you. So I'm going to just start with a general case, and this will allow us to walk through the guidelines and how we came to the recommendations that we'll be making. I will say that we're not talking about specific, very specific populations like those who are inpatient or those who are pregnant. Those are available in the guidelines, but I wanted to give you a broader overview of some of the major recommendations and how they're different than other SROM guidelines that are available. So this is a 36-year-old man. He lives in an encampment. His drug of choice is fentanyl, largely smoked, mixes it with methamphetamines. He's very treatment experienced. He's been on methadone multiple times with doses well above 120 milligrams. He's been on buprenorphine naloxone over 32 milligrams at times, as well as extended release buprenorphine. He's coming into your RAM clinic, so I'm assuming you're a prescriber or you might be seeing him in another context, coming into your RAM clinic asking for SROM. So this is a patient who's presenting asking for this. So we get a little bit more information about why Ted is really interested in SROM, and we find out that he had really unbearable sweating on methadone. He felt like he needed a higher dose of methadone, but was told he couldn't go above 120 milligrams. Not only did those high doses make his sweating worse, but there was something about his heart that was a problem. He felt like buprenorphine naloxone and Sublocade or extended release buprenorphine made him use more to overcome the effect, and he didn't like the way it made him feel. His goal, he tells you, is to reduce his use so he can prevent overdoses, and he has had an overdose in the last 6 months. So we're going to talk about the evidence for SROM as opiate agonist therapy. There really are very few high quality studies. So randomized, double-blinded controlled trials are really not what we're talking about in this case. If you compare it to something like methadone that has many, many decades of research available. There are 5 systematic reviews of SROM as OAT that have been published in the last 10 years. But I will, again, use the caveat that lots of the interpretation of this data is based on those expert opinions that we talked about before, because the data is very limited based on the weakness of study designs. We're mostly talking about crossover studies, usually involving methadone, much less available with buprenorphine, very small sample sizes and short duration of follow-up. And the other issue is that lots of these studies use very different outcomes, which limits our availability of kind of combining them together in systematic reviews and meta-analysis. So we can't use, the multiple populations to come together to have a bigger sample size, which is a bit of a problem. So the aspects of SROM care that we can fairly confidently say based on these systematic reviews that we're able to make some conclusions on in that iterative process we talked about are the following. So if we look at retention, there's a Cochrane review that was published in 2013 that basically showed us through these systematic reviews that really retention in treatment, meaning those people who stayed on SROM, were very similar between methadone and buprenorphine. There were 2 meta-analyses that compared SROM and methadone together that also had the same outcome. And then there was a prospective study that was very interesting that basically, people chose which treatment they wanted to be on. And interestingly, SROM had a much higher retention rate compared to methadone and buprenorphine. And there's lots of reasons why that may be there, especially if patients have choice. And if people voluntarily switched from methadone or buprenorphine, the retention rate was about 60% on SROM. And for those of us who work in this area, you know that that's an excellent retention rate. In terms of substance use, again, those same 2 meta-analyses, there was no difference in these meta-analyses. They were looking at heroin use. That was the primary drug of choice amongst the patients who were enrolled. So it kind of tells you the era that these studies were done in. But there were no difference in heroin use or other substance use in the 2 populations. So again, kind of showing us that SROM is non-inferior to methadone if we could have those kind of larger sample sizes. And those who voluntarily switched from SROM from methadone and buprenorphine had a significant reduction in their substance use compared to what they were using while on methadone and buprenorphine. And then another study, again, a 50% reduction in their substance exposure. Cravings are obviously a difficult outcome to quantify. And again, that's probably why we don't have meta-analyses, because different studies use different outcomes to quantify cravings. But we do have 2 prospective studies and 2 crossover studies. So basically in the crossover studies, people started on methadone and then switched to SROM. And what they found in all 3 of these studies. The prospective study, meaning people started on SROM and they stayed on it, was a self-reported reduction in cravings. And again, I think this patient experience response is really important for us to include when we're thinking about providing treatment and the importance of it. In terms of satisfaction, so if you asked the patients in these studies, were they satisfied with their treatment? In open label studies, crossover studies, where they basically knew when they were on SROM and when they were on methadone, as opposed to being blinded, satisfaction was very, very high on SROM, and many more people reported feeling quote unquote normal. And again, I think this is a very important part to include when we're talking about adding another opiate agonist therapy. There were 3 studies that showed improvements in mental health, so anxiety reduction, depression reduction, and an overall improvement in mental health compared to methadone. Unfortunately, we don't have any studies comparing this reduction in mental health outcomes with buprenorphine. So that would be an area for future research. And so it's very difficult to say with confidence whether those would be reduced. But again, I think given that we do have a couple of studies involving methadone, it certainly tells us that this should be included as part of the evidence to support this treatment. So based on largely the 4 components I talked about here, retention, substance use reduction, and then the craving, satisfaction, and mental health outcomes, the recommendation that we will make in the upcoming guidelines is that SROM should be considered as an OAT option alongside buprenorphine and methadone. And really, we're trying to place it as an equal option compared to the other OAT options that have historically been available. And really want to reinforce, and hopefully these guidelines will provide you, for those of you who are prescribers, the confidence to go ahead and prescribe this without expert consultation or additional consultation moving forward. So what I often get asked as a prescriber who's been prescribing SROM for a very long time is about safety. So a lot of this is anecdotal or based on our knowledge of the molecule and the pharmacokinetics and the pharmacodynamics. But basically what we know is that because SROM is a full agonist, it's similar to methadone in terms of how it works, in terms of increasing doses, have increasing effects at the mu receptor. We expect it to have similar side effects to methadone, and more side effects compared to buprenorphine because of that full agonist effect. We do have one study from palliative patients who were either on long-acting morphine or on methadone, and what we found was there were more side effects on methadone in those palliative patients. So not using it as opiate agonist therapy, but in this realm, there is actually a lot of literature to support long-acting morphine in palliative patients, and I think this helps to inform what things we should be looking for as we gain experience in this area. If you look at the crossover studies between SROM and methadone, so those people who switched from one to the other, basically what we found was there's no difference in side effects. In terms of drug interactions, and we're going to talk a little bit about this more when we talk about people who aren't suitable for SROM for a variety of reasons, but there are limited interactions with morphine compared to methadone. So if you're looking for a full agonist and they're not suitable for methadone for a variety of reasons, this really is our kind of go-to. There are some interactions with some benzodiazepines, and we spell those out in greater detail. And there are some interactions with calcium channel blockers as well. And as well as some TCAs. Luckily, TCA use in the province has reduced, so that's less of an issue. The biggest benefit, if you need to use a full agonist compared to methadone, for at least in my inpatient work as well as in pregnancy, is the limited QT prolongation. It is not considered a QT prolongator, generally speaking, and as a result, there's a very limited risk of torsades, which is really exceptional for those people who are very limited in their dose on methadone and want to be on a full agonist. So the second recommendation that we came up with was really kind of thinking of it in the context of what are some specific populations that SROM may be useful for, particularly understanding the context of hesitancy in prescribing SROM because it is the newer kid on the block. So if you have a patient who has severe opiate use disorder and high risk opiate use, does not have to have failed methadone or buprenorphine, or does not have to be treatment experienced. But again, given the severity of the poisoning crisis, this is a very important tool in our toolkit. Patients who have had unacceptable side effects and other OAT, have ongoing cravings or withdrawal with other opiate agonist therapy. And Ashley really kind of gave us a good understanding and context of what that can look like in some scenarios. And those who are very high risk for prolonged QT or torsades. So if we go back to Ted, he wants to get to a good dose quickly and wants to know what his starting dose will be. He really wants to know the nuts and bolts of what this is going to look like because he is very treatment experienced. He wants to make this a successful process for him. His past medical history is he's got untreated Hep C, no evidence of cirrhosis. He has maybe this history of prolonged QT on methadone. We just know that there's something with the heart and he wasn't able to go above 120 milligrams. He has no surgical history. As far as we know, his kidneys and his liver are functioning well. So the next part, we really need to understand the actual structure of the molecule we're prescribing or we're suggesting to our patients. So we're talking about a slow release oral morphine formulation, which is trade name Cadian. It's morphine sulfate sustained release capsules. It's a once a day, 24-hour formulation, and the goal would be to get to a dose that reduces cravings and withdrawal with a single once a day dose. It has two types of beads in it. It has immediate release, that's the IR, and the slow release morphine. So this is really where it's very important to understand how this medication works. It's got a gelatin capsule that dissolves in the GI fluid. So you have to have a working stomach for this medication to work. One of the pores in the beads releases the IR morphine, so the immediate release in the stomach, and you have to have an acidic pH. We don't have good data about how proton pump inhibitors and H2 antagonists may impact this, but anecdotally speaking, we think it's probably okay, but it's something you have to kind of counsel your patients about. And then the longer acting morphine is not released until we get to the small and large bowel where there's a higher pH. So we need that function from a low pH environment to a high pH environment to get release of both of those medications. And the reason I'm really harping on this is we need to understand how it works because that will tell us who is not suitable to have this medication. The other thing I wanted to draw your attention to, and you have to speak to patients about this because they'll be very confused, especially if they're treatment experienced with methadone, is that the peak effect is very different. So the peak plasma levels for SROM are probably about 8 to 10 hours after you take it. You can see in this graph on the other side, these open dots have a later peaking time. Unlike methadone, where people are used to having kind of that sedative nodding off effect at 2 to 4 hours after they take it. So you have to explain to patients they may not see that peak effect until later. And again, because it's a full agonist, you really get no ceiling effect. The steady state is about 48 hours after you take it, unlike 3 to 5 days for methadone, which means that you can titrate it much faster. So the contraindications, obviously, if you have hypersensitivity to morphine or any of the non-medicinal ingredients of it in it, because morphine, similar to methadone, is a full opiate agonist, acute or severe respiratory depression is going to be a contraindication similar to asthma and COPD, particularly if they're severe and have recurrent exacerbations. GI obstruction, including ileus, is a contraindication because obviously you're not going to get movement through that small and large bowel to get that pH change. So this is something that if you do inpatient work is always a bit tricky because we need a working bowel for this to work. MAOIs luckily are less common now. And chronic kidney disease is the other one I really want you to think about because you can get buildup of morphine metabolites because they're renally excreted. So you really need a eGFR over 50. The relative contraindications are those that have GI issues that affect gastric emptying, things like obstruction, diarrhea, abnormal gut anatomy, those who might have undergone Roux-en-Y, not overly studied in those who have had other types of gastric bypass surgery. If you have a GFR that's between 50 and 90, you have to remember it's very easy to have your renal function acutely reduced if you're dehydrated or you take other nephrotoxic medications. And that really puts you at risk of toxicity. So that's something to really think about. And then the other thing is that folks who also drink alcohol, co-ingestion of the alcohol acutely raises the morphine levels, increases your opiate plasma concentrations. So this actually can be fatal. So you need to be very, very aware of that. Hepatic dysfunction, because again, you need, we need to be able to metabolize this medication. And then those who are at higher risk of opiate toxicity, and this would be similar to methadone because they're both full agonists. So older age, COPD, which we talked about in the first slide, sleep apnea, concurrent prescription of sedatives, you're going to start lower, go slower, or can consider buprenorphine. So this is probably where things differ the most in terms of starting doses for monotherapy. For those of you who've been prescribers for a while, many of us use the BC SSU document that basically started people around 30 milligrams, maybe a maximum of 100. And we're going to talk about why these doses are much higher. But if you particularly look at the high tolerance folks, what we're recommending is starting doses in the 200 to 400 milligram range. Generally speaking, we're talking about people who have high tolerance, usually to fentanyl or fentanyl analogs. They have regular exposure, regardless of the route of administration, and they have no toxicity risks. For those who have risks of toxicity, which we just talked about in terms of the, relative contraindications, then you may want to start them at a lower dose. And we'd particularly be worried about those who have intermittent exposures. So those who might be using once a week or twice a week, who may not have the same level of regular exposure and higher tolerance. So this differs quite a lot from other guidelines. And really, it kind of comes down to clinical experience and expert clinical consensus. So when you read the guidance document, it will not read like your typical guideline where we can cite 50 papers that say this is the starting dose and this is why. But I'm going to tell you why in 1 minute. I'm going to show you some math. We want to really reinforce that this is specifically to the 24-hour once-a-day formulation of slow-release oral morphine that I talked about previously. This is a brand name Cadian. And there's going to be significant individual factors that you take into account because, again, we don't have, the 40 and 50 years of data to go back to look at. So this is really an area where using the art of medicine is very important. So things like opiate tolerance, concurrent substance use medications, other medical conditions, but also the risk of death in the patient that's sitting in front of you is going to inform whether you start at low, medium, or high tolerance doses. So the considerations for some of the SROM doses really kind of comes from many of our experiences with methadone in particular. So we do have recent clinical experience, including some virtual care data from Canada that say that you may be able to start doses for everyone who uses fentanyl in the 30 to 50 milligrams of methadone range. And we have lots of accepted conversions of methadone to SROM, anywhere between 1 to 4 and 1 to 8 in the literature. So I just picked the midline, which is 1 to 6 conversion. So if we have 50 milligrams of methadone, again, we have some Canadian data to support that as a starting dose. And if we multiply that by 6, we've got a starting dose of 300. So remember I said for high tolerance, we're thinking of 200 to 400 milligrams of SROM. So that would really put it smack dab in the middle. You do have to remember though that SROM probably is slightly safer in terms of QT prolongation than methadone. So that's something else to consider. The other clinical experience that we have is, again, some Canadian studies that have shown that people likely can start on 30 milligrams of methadone and 200 milligrams of SROM in a mixed paradigm. And again, if you were to convert that 30 milligrams of methadone to SROM by multiplying by 6, your starting dose would be 380 milligrams. So that's basically where that 400 milligrams of SROM came from as a starting dose. So really, this is just some, quick and dirty math for us to look at, but really informs our starting doses. Our titrations, you're going to increase for those high tolerance folks by 200 milligrams every 48 hours until you get to 800 milligrams. And then it's going to depend on the ongoing tolerance of the patient. So that 800 is kind of our cutoff. You can see 50 to 100 milligrams for those who have moderate tolerance, and then lower for those who have low tolerance or high risk for toxicity. The literature maximums, interestingly, are about 1,200 milligrams. You do have to remember that the vast majority of these studies were done largely in the heroin era or the prescription opiate crisis. So we know that our patients' tolerances are significantly higher now. There is no maximum daily dose, just like there really is no maximum methadone dose, although we do have to be careful about some of the specific components of methadone. In terms of clinical experience, we have had patients on well over 2,000 milligrams, and that's I think over 2,000 milligrams is not unusual in my particular patient population. So our goal again is to minimize withdrawal. We want without sedation and minimal side effects for our patients. Some of the things to kind of think about, and again, this is very different than the previous iterations of guidelines, is that really you may want to put on your prescription when you write it out that the pharmacist can use whatever combination of strengths of capsules available to make the total daily dose. There's nothing worse than writing it as Kadian 100 milligram capsules, and then the pharmacy doesn't have it in stock, and it's 50 phone calls back and forth. So if you just put that as an option on your prescription, then the pharmacist can make up the total daily dose. We are advocating that the capsules should not need to be opened and poured into a cup for observed dosing. It's a workflow issue for the pharmacist, so patients may have to wait around a long time until someone's available to open all the capsules. There may be retained pellets due to static in cups, and then you've got to obtain yogurt or applesauce. And it's really a barrier and stigmatizing. So everyone's watching you in the pharmacy wait because the pharmacist has to do something special for you. So we recommend that the capsules be swallowed whole, that they take a drink afterwards. For those who are on methadone, you could swallow your methadone after your Kadian if it is an observed dose. So our third recommendation is that SROM starting doses should be based on individual opiate tolerance. They can be as high as 200 to 400 milligrams, and there's no maximum daily dose. So if we go back to Ted, let's assume that he was on methadone and wanted to switch to SROM because he's got a prolonged QT and he doesn't want to be on the combination. He just wants to be on one therapy. So really what we're trying to talk about here is there's lots of controversy about how to do these conversions. So there's one method, which is you stop the methadone, start the SROM, or you do a cross taper. Really, our concern as a group was the abrupt stop and start might result in higher rates of withdrawal while doses are being adjusted, because remember, you have to change the the dose for cross tolerance. So you're not probably going to hit the dose immediately. And so there's lots of things about individual circumstances that should be taken into account. So cross tapering, there is an unpublished study that really kind of looked at a protocol, and this is, we talk about this in the guidelines in more detail, but the idea is that you would drop your methadone dose by 50%, and then you start the SROM dose at 25 to 30% of your anticipated final SROM dose. So you would multiply your methadone by 6, and then you would give 25 to 30% of that final SROM dose as a starting dose, and then you would slowly titrate down from there. And this is probably the most evidence-based protocol that's not yet published, but really informed what we're going to recommend. So our fourth recommendation was that cross tapering may be more appropriate than abrupt start and stop, just because patients may be more comfortable, and that the usual final dose of SROM is somewhere between 1 to 6 and 1 to 8 of methadone. So basically, Ted wants to talk to us about carries, or he wants to talk to us about missed doses. We get a call from the pharmacist. He's missed 3. Historically, missing 2 would have caused a reduction in your dose, and the pharmacist wants us to know what we'd like to do. So previous guidelines reduced the dose of SROM by 40% with 2 consecutive missed doses. This caused significant issues for patients in terms of getting to a stable dose. What we are recommending is that, particularly for those who have clinical experience with unregulated opiates and ongoing use, who have ongoing tolerance, is that you can actually follow the recommendations that were in line with the PHI methadone for those who use fentanyl guidelines. So basically 3 missed doses, you continue your previous dose. On the 4th day, you reduce by 50%. Except for those people who are on doses higher than 800 milligrams, there's some evidence that we may have to reduce after 2 consecutive missed doses. But again, using that clinical experience and knowledge of the patient and patient preference in terms of knowing that there's individual tolerance circumstances that may actually have you change that recommendation. So recommendation 5 was no dose adjustment for 3 consecutive missed doses and not reducing until the 4th day. Again, we are dealing with a poisoning crisis. We want to make sure that people are on a semi-therapeutic dose as quickly as possible. So Ted is very interested in getting carries. He's been on SRM for 3 months. His dose is 1,200. He hasn't missed a dose in 2 months. He recently received ODSP, is now housed. I'd love to know how he got housed. But he's wondering if he can start building carries. So the first thing is, how often should we do urine drug screening? Obviously, up to 4 times a month is pretty standard in most guidelines. You know, long-term carries 6 or more, you're probably going to be looking at least 1 every 1 to 2 months, having more frequent, and then maintenance of methadone for or SRM for people who are not building carries, you can go down to once a month. So the caution I have here in terms of interpreting urine drug screens is, again, remembering, and there was just a topic about this on the Metafied listserv recently, is that there are certain things that are going to be common when you are dealing with morphine as your substrate. So you will find on point of care, because most of us don't have access to mass spec, you're going to find morphine, you're going to find hydromorphone, particularly if they're on high doses. So doses over a couple 100 milligrams is pretty much always going to have hydromorphone, and then you'll have trace levels of codeine as well. So those are all known findings for morphine and should not negatively impact people's ability to get carries. So the SROM criteria is very similar to the methadone criteria. So they should be on it for at least 4 weeks. They have to be able to store their medication safely, stable mental health, no missed doses or appointments, not using substances in high risk ways. So not injecting, not having blackouts. So have some evidence of clinical stability, and really why we're going to advocate for giving up to 3 non-consecutive carries a week is this maintaining the treatment and building stability and allowing patients the opportunity to engage in their care. Those who've been on it for 12 weeks minimum are clinically and socially stable, can get up to 6 carries. And we're advocating for a maximum of 6 take-home doses because, again, there's really no literature in this area. And we're really kind of advocating for this based on those expert opinions. This is the caveat that there are likely harms of carries with SROM, and this largely comes out of a French study and some experience in Europe. But basically, crushing and chewing the pellets can cause release of the entire morphine bolus dose at a single time. And as I mentioned, co-ingestion of alcohol can be incredibly toxic. So for those folks who may be more unstable with ongoing injection use, we may have to use a bit of caution. So a recommendation, take-home doses based on clinical stability, start with non-consecutive carries, max of 6 carries for those on SROM, more than 12 weeks with clinical and psychosocial stability, and then care taken with those who may be at high risk of diversion or altering their route. What I'd like to do now for probably the last few minutes is hand it over to Ashley and Jason to talk about the patient decision tool that was part of the development of the guidelines and the how they came out about this and how it's going to kind of change the treatment pathway.
So I guess I can start. For this, I think how it came to be was like we had a lot of meetings, we had a lot of discussions, and there was so many tools that we were creating for doctors, and it was very complex and like very, I don't know, hard to understand if you were a patient, and all these different pathways and options. So throughout our process, there was this decision-making tool kind of thing that came up. So I think we kind of decided to adjust that and kind of tweak it to make it for like patients, so patients could make decisions on what medications they wanted to take. I thought it was going to be like an easy process for the patients, but then in the end, I feel like it might be a little overwhelming. So like the doctor might have to sit with the patient and like, you know, go through it still. But I think it just provides the autonomy to be able to make those decisions and that information and kind of feel like you're in charge of your healthcare. Jason, do you have anything more to add?
I reiterate all those points, and one of the hardest challenges I found was the language, just coming up with the right language to use so that we're meeting people where they're at in life, in education, and experience. I found that a very difficult process, but the guide, this decision-making tool, was developed by people who use drugs, for people who use drugs. So, and we included others in the discussions when developing this tool for feedback, revision, and it was a long process, but I think a very fruitful process where we get to include, and what I said at the beginning, to include people in their own path to whatever goals they have, to empower people to be a part of their health, and just to make informed decisions as to how they're going to proceed. So, yeah, it was a great opportunity, and I really enjoyed it. So, I enjoyed working with everybody in the group. So,
one of the things I really liked about this tool was these last 2 slides, kind of talking about your feelings. And I love this part of the tool where, saying if something is important or somewhat important or not important, and then having, this very important and part of the table is really nice. It kind of gives this very like dichotomous view of these are the couple of medications you might want to consider if that's really important to you. So I really liked that part of this tool. I think it's something that I can really see using with my patients. And then the other things I liked about this, which I think is very accessible to patients as well, is about you and opiate agonist therapy. Like, do you drink alcohol? Then you might not be a great candidate for SROM. Do you have problems with your heart? And I can see this also helping me to recognize what patients are worried about. So I might not recognize that my patient is worried about their heart. I might not have said, oh, hey, like I'm actually not worried about your heart at all. So I think having the perspective and kind of this decision making set of tools that was developed for patients by people with experience has been really, really valuable.
Well, like the options, some people don't even know what their options are. So like having those conversations can really open up like even that trusting relationship and building that rapport that's so necessary.
Absolutely. So I'm going to stop sharing and then kind of come back into this scenario, and maybe we can stop and take some questions from the group with our last sort of 7 minutes.
Thank you all. Oh, I gotta get my camera back on here. Here we go. Yeah, lots of questions rolling in the last bit, and you guys provided so much information, but of course we still have so much we're wondering. So I'm just going to start here with Lori's comments. So she was just commenting on the shortages of SROM, that we have had a couple of shortages come up in the last couple of years. And just in terms of contingency planning, is there anything that we can do to plan for this? And then she did have another question as well, just for co-administration of methadone. I'm not sure if she meant in regards to if there is the SROM shortage and, how we would adjust.
Yeah.
You're able to comment.
So we do actually talk about this in the guidance document. Obviously, we had limited time today, so I really kind of wanted to focus on those high yield components. So basically, you're going to have to switch to MS Salon or MS Content, which isn't ideal because there's risks of errors in terms of switching and those kinds of things. In terms of the dosages, some of us will put on all of their SROM prescriptions that if there is a shortage, you can automatically substitute MS Salon or MS Content in this way. And it's not ideal, certainly, but we're not dealing with an ideal situation by any means. And then in that case, you are going to have to either think about in terms of the clinical stability of that patient, because those drugs are dosed twice a day, whether you are going to give a carry for the second dose, or whether you're going to have the patient go back to the pharmacy. And that's really good where the clinical relationship with the patient is going to come into play in terms of safety and whether that's an option. So certainly not ideal. And unfortunately, we deal with lots of shortages in this space in terms
Absolutely.
of lots of medications, unfortunately.
Sure. I just unmuted folks in the audience, so I was just going to call on a couple of folks there because Mark had a couple comments in the chat, but he's also got his hand up. So I'll just call on you, Mark, if you just want to press down the hold to talk button as you speak, if you're able. Probably tricky. This is a new one for us. Don't think there's anything I can do in that regard. Mark, are you able to unmute yourself? Oh, sorry, not unmute. Are you able to hold down the talk button? And might not be able to.
I think Was Mark asking, I see one question about pharmacists and the education.
Yeah, and Jennifer kind of spoke to that a little bit, just
Mhm.
about educating and getting that information out there, because we do get pushback, right, with these new guidelines.
100%. And we had lots of conversations about this, and this is where it was very valuable to have a pharmacist member of our team, which was really lovely. If you look at BC in particular, I think one thing that I really valued from their rollouts of things like SROM even a few years ago was that they had regular kind of education pamphlets and webinars for their pharmacists, and 100% the pushback from pharmacists is a issue. But now that we actually have published guidelines, I think it's a bit harder for the pharmacists to push back. So once these become available, because previously I had to send them the BCSSU guidelines, and then they would say to me, but you're starting 400 milligrams of SROM and not 50, and why can I dispense this? How can you expect me to dispense this? So I'm hoping that with just having something actually laid out, that we'll be able to engage our pharmacist colleagues in a discussion and an open conversation about why we came to these understandings. But 100% it's going to have to be kind of a collaboration with our pharmacist colleagues.
Sure. Couple questions about alcohol. So I guess how much is too much when you're prescribing this? And also kind of related just also around toxicity. So if people are also continuing to use fentanyl, how concerned should we be?
Okay, so let's start with the fentanyl. That's maybe a bit of the easier question for me as a prescriber. So we know that these starting doses for the most part are not going to be sufficient for patients with high tolerance, very similar to methadone, right? And what we do know is that probably, I'm assuming, just based on methadone literature, that the first 2 weeks of titration are going to be the most high risk times, because you're titrating to a dose that hopefully will reduce substance use if that's the patient's goal. I certainly don't see it as any more dangerous than methadone. And certainly I think you can speak to your patients about, like, these are the risks, and I'm going to titrate this, and we're going to do it as quickly as we can, but there is a risk of overdose. But this is certainly, you have to remember, once you get to a higher dose and there's tolerance to that dose, that's actually protective against overdose. So I think saying that is very helpful. Like, this actually will help reduce your risk overall. Maybe Jason and Ashley have some suggestions about that as well.
I can speak to alcohol use from a personal perspective, as alcohol was one of my drugs of choice. So at the time, I just discontinued alcohol use. So I just thought that maybe that was a better decision for me at that point in time. So it took me a while to come to these conclusions. But what Adian did was it allowed me to formulate better decision-making abilities and kind of guided me down a path where I can make some choices for myself. So, and again, through the empowerment of being included in my recovery, choices I could make, because I certainly, coming from a small Northern Ontario town, I didn't want to stand in line at the pharmacy because I had a job to do and I was a manager, and I didn't want that stigma and that sort of judgment placed upon me. So, and as I proceeded, I just decided I was going to quit using alcohol, and I was going to quit using even marijuana. So it was just, it's just the path that worked for me. Not advocating for abstinence, I'm just advocating for choice. So I chose to leave using alcohol, and my doctor did at the time counsel me to stop using alcohol, but it was ultimately my choice, because of course I could have just lied and gone about my merry way and nobody would have known the difference. So from a pharmaceutical or a doctor's perspective, I'm not sure, but from my perspective, that was just my choice. So.
Thank you. So we got loads of questions here. I don't know if we're going to have time or if you guys are able to stay on a little bit longer, but
oh, hi. I think you have to hold it. I realize you can't just click it. You have to keep it down. Okay. Thank you very much for all of your work on these guidelines. I really appreciate it. And I do use SROM a lot with my patients. My question is around the take-homes. I mean, I respect the need for patient input and expert opinion. The only real scientific evidence we have is that huge population study from France, which shows the odds ratio of 2.2 for overdose, the Burton study from a few years ago. And given that, I feel really uncomfortable with the recommendation for a similar take-home policy to methadone without supporting evidence. I mean, I think it's always going to be a balance between, trying to be patient-centered, but at the same time, given the potential impact on the individual itself, because that odds ratio of 2.2 is actually just for the individual and doesn't even take into account the population. I really worry about that recommendation.
So I think this was a long discussion. I think that the population in the France study was very different than the population we're dealing with today, and our patients overall have a higher risk of overdose death from exposure to a toxic supply. We will never have evidence currently. I think what sort of informs this is that we don't want an option for OAT that actually may benefit in terms of people's overall overdose or poisoning risk, fentanyl, to limit their willingness to engage in a treatment option because they will never be able to get carries. And I think that's really the crux of the issue that we had long conversations about. And certainly we have to kind of take our patients' understanding into account. Certainly there are risk factors that are going to be higher risk. So if patient is still ongoing higher risk exposures from injection, for instance, then generally I will not grant carries because that's an ongoing risk, particularly if they inject their Cadian. They're going to have not only the risk of the injection of a huge bolus of morphine, but they're also going to have the risk of things like fungemia and other kinds of infectious processes. So, I mean, I think at the end of the day, we can only go with what the guidelines sort of recommended based on that group of people who sat there, and I'm respectful of that opinion. I think the overall discussion and concern was really that we're dealing with a different entity in terms of the overall risk to our patients in terms of the poisoning crisis.
Yeah, I mean, I guess that's the same position for a safe supply. I have serious concerns because I know often, I have people who are on 1,500 milligrams of Cadian who probably, if they were taking it home, wouldn't need it all, even when they're stable. And, it is a risk. So anyway, but thank you. I appreciate all your work on the guidelines. I just wanted to say that.
I will say that I also have patients who've been on, 2,400 milligrams of SROM for long periods of time and take their doses every day with carries. So, it kind of comes down to, yes, there's risks. And we have to kind of decide as a group which risks we're going to take.
Thank you.
One should do some research on carries and make that evidence. If everyone's going to, pass the buck and say we need evidence, then maybe gather some. Yeah.
And maybe if we're going to make this a person-centered approach, we make it a person-centered approach, and both parties need to establish rapport and advocate for each other. And I think certainly with my recovery, I was given take-home doses, and I flourished. And I'm not saying that's the norm. I'm just saying I had a good rapport with my physician, and my physician and I talked about this, and there was some boundaries set in place. So If we're going to take a person-centered approach, let's take a person-centered approach.
I know we still have loads of questions and everything going on here. So I just did want to take time to thank everyone for attending and for our speakers for going over all this. For this is a really important topic, and to remind people to do the session survey. There's a link, a couple comments back now, but I can try to post that again. And just to let people know that we are on lunch after this, and to just please come back at 1 o'clock.